Yes, we are live on YouTube now. So good morning, friends. Welcome back to Saturday Club morning meeting. And today we have a very interesting topic to discuss, and that is about recent advances in management of tuberculosis. You all must be knowing that there is a very well organized program called NTEP, that is National Tuberculosis Elimination Program. Earlier, we used to have revised National Tuberculosis Control Program. Now the government is aiming at eliminating tuberculosis. And it's a huge, ambitious program, and we have been all witness to the kind of sincerity with which the people are working on this program. And to update us on this, we have very eminent speaker, Dr. Hardik B. Nakshiwala. He did his MBBS and MD in Preventive and Social Medicine from our own Baroda Medical College way back in 2015. Then he worked as an epidemiologist in district as well as state NCD cell from 2015 to 19. Currently, he is working as medical consultant in WHO Technical Support Network since 2019. And is looking after a DRTB, TB preventive treatment, and private sector engagement. So welcome, Dr. Hardik Nakshiwala. Thank you for accepting our invitation to be part of Saturday Club group and coming as a guest speaker. So
Thank you, sir.
Over
Thank
to
you.
you. You have about 45 minutes to talk, and then we'll have 10 minutes of interaction. So
Sure, sir.
over
Thank
to
you, sir.
Thank you.
Good morning, all senior faculties and my colleagues. So first of all, thank you for giving me this opportunity. So I am actually looking after Vadodara zone and Daman Dadra Nagar Haveli for this National TB Elimination Program. And I'm here to share mainly how this evaluation of National TB Elimination Program came to place, then recent advances and our way forward for ending TB. So elimination may not be possible till 2025, but we are going to end TB as a public health menace. So we will see, and I am sharing my screen. So for 40 to 45 minutes, I will mainly present this NTEP advances, and after then we can have our question answer session.
Sure.
So my screen is visible.
Yes. Well visible and well audible also. Please go ahead.
So let me know if there is any interruption in net or my audio or video, sir.
I will call you up if there is any problem.
Sure, sir. Sure, sir. So first of all, so there is the burden of TB, and it is from the Global Tuberculosis Report of 2021, which have the data of 2020. So India usually share 1/3 of the global burden for TB incidence, TB mortality, and multi-drug resistant TB. So from 2019 to 2021, in the Global Tuberculosis Report, we used to share 1/3 of the global burden in terms of incidence, mortality, and multi-drug resistant TB, right? But what is not shown here is TB infection. So if you imagine a monster with a big head, 3 to 4 times big head than its tail, having a head, then a torso and the tail component, then the biggest head, which is 5 to 7 times, is TB incidence, that is LTBI or latent TB infection. Then its body, it is DSTB, that is drug sensitive TB, and its smaller tail is drug resistant TB. So we used to elaborate this burden of TB by saying this, and I want to reiterate that TB infection and control of TB infection is the key for ending the TB, right? So the burden, we usually share 1/3 of the burden, and globally we have 33% of TB infected cases. So India has the highest burden of TB infection, and we have 35 to 40 crore of TB infected cases. And when we get TB infection, the lifetime probability of getting or breaking up into the TB disease is 10%. But if we have HIV, then this probability increases 10% every year. So by that mathematical modeling, we are getting 26 lakhs of incident TB disease case annually, right? So 1/3 population is already infected with TB, and from these 1/3 population, we are getting TB disease annually. And we are knowing TB for more than 5,000 years. But what we are doing is we are detecting and treating TB disease, not TB infection. So identifying TB infection and treating TB infection will be the key for elimination as well as ending TB, right? So if you get TB infection, then breaking up to TB disease will be there within first 2 years. And it is more common in Indian context that people will break up into TB disease after getting infected within 1 year with 75% probability, and within 2 years with 97% probability. And molecular fingerprinting studies have confirmed that probabilities of developing disease after getting TB infection from the source of TB disease patient will be 45%, 62%, and 83% respectively within 1, 2, and 5 years, right? So after getting infection, breaking up to TB disease will be dependent mainly on immunity, right? So host immunological status mainly depends on his probability of getting or breaking up to the TB disease. But the risk is more than 25 times among contacts of pulmonary bacteriological confirmed TB patients. So there was a study done in Mednipur of Uttar Pradesh, when they have found the probability proportion of TB infected cases in the household contact of pulmonary microbiologically confirmed TB patient to be 71%. Right. So household contact of pulmonary microbiological TB patients will have more chances, that is more than 25 times increased risk of TB infection in their life. It is 16 to 21 times in HIV co-infection and 3 to 4 times in immunocompromised disease like diabetes. Right? So TB preventive treatment is the key and will be the game changer, and it will additionally be supported by our BCG vaccine within 2025. So TB infection, managing TB infection, TB vaccination, and preventing airborne infection control will be the key strategy for ending TB and for elimination of TB. So epidemiological modeling studies can show that in India, we are having decrease in incidence rate 1 to 2% every year if we continue our detection and treatment policy, which is there in the RNTCP. But if we incorporate prevent part comprises mainly TB preventive treatment and airborne infection control, it will reduce the incidence drastically, 8 to 10% per year. So that this is the mathematical modeling which I want to show you, that without doing any intervention, we are continue to getting drop in incidence rate 1 to 2% every year. But if we want to end TB or if we want to eliminate TB, then we have to drastically reduce the incidence, which can only be possible by treating latent TB or by treating active and latent TB. That is the 4th and 5th part of the intervention. Right? This is mathematical modeling, and from this modeling, our whole end TB strategy rely. So this is the highest level of commitment shown by our Honorable Prime Minister, because in DOF strategy, the first sentence was political commitment, but it was not shown from the highest level. So in 2018, our Honorable Prime Minister has launched this TB-Free India campaign and call for the social movement. And that is the reason why we have incorporated TB preventive treatment, airborne infection control, and the whole strategy of National Strategic Plan has been changed to detect, treat, prevent, and build, right? These are the 4 pillars of the National TB Elimination Program. And it is only be possible by showing the highest level of commitment shown by our Honorable Prime Minister. And the commitment is to end TB by 2025, that is 5 years prior than the SDG target. And the main goals are reduction in TB deaths by 90% in 2025 compared to 2015 level. Reduction in TB incidence by 80% by 2025 compared to 2015 level, and any TB patient or their family will not have any catastrophic cost due to TB by 2025, right? That is the commitment shown by our Honorable Prime Minister to end TB. So this is the all over game for National Strategic Plan or for ending TB. And you can see that this dotted lines, that is the continuation of the reduction in incidence with only controlling the program. And you can see the drastic incidence reduction by seeing this gray colored line, continuous gray colored line, that is bending the curve by incorporating preventive strategy in TB, which mainly comprises TB preventive treatment, airborne infection control, newer diagnostic tool, that is incorporation of NAT at every block level, newer advances in diagnostic methods and operational research. So what we are going to cover mainly is the TB preventive treatment, right? So what I have already shared, that this is the National Strategic Plan, and it mainly comprises of prevent, detect, treat, and build. Prevent is the key part for the TB elimination program, and build comprises adequate funding, human resources and capacity building, community engagement, and newer researches. So this is the game changer, and it will have many challenges when we operationalize this PMTPT, that is programmatic management of TB preventive treatment. So the aim is to have significant impact on individuals' health as well as to reduce TB burden and transmission. And we are going to provide TB preventive treatment to target population, which I will share in the next screen. But the basis of providing TB preventive treatment is shown in this algorithm. So first of all, this is the golden sentence for providing TB preventive treatment or for managing LTBI or TB infection, that active TB is the absolute contraindication for TB preventive treatment. WHO has said and has published the document for TB preventive treatment, and globally it has insisted to start TB preventive treatment if you want to end TB by 2030 as per SDG. But in United Nations high-level meeting, we have also committed to start TPT by 2019, but due to COVID, we could not start. And now 2022, we are starting TPT countrywide, first for the pulmonary bacteriological confirmed TB patients contacts, right? So these are our lower hanging fruits, and we all know, and in previous slides also I have shared that contacts of pulmonary microbiologically confirmed patients have 25 times higher risk. So we are going to target those population mainly. right? But before initiation of TPT, active TB is absolute contraindication for TPT, right? So before initiation of TPT and during TPT, a clinician or doctor have to rule out TB whenever possible. Whenever he meet the patient or the beneficiary, he has to rule out active TB. If there is active TB, then rule out active TB as stringently as possible. And if the patient is not having active TB, then the patient should be prescribed or should be allowed to continue TPT, right? So rule out active TB is the key for before providing TPT. If patient has presumptive TB, then try to confirm TB. If TB is there, start TB treatment. But if TB can be ruled out, then patient should be tested for TB infection as per national policy, will be evaluated for TPT, and if patient is not having any contraindication that are the relative contraindication, then we can start TPT, right? But absolute contraindication is active TB, and our government has started giving TPT statewide from January 1st, 2022, right? So the public sector patients have been providing TPT right now, and you will have this type of patient in your OPD when this patient will be having TPT. So how can we test TB infection? So TB infection can be tested by TST or Igra, but it is not mentioned here that the company which is producing this purified protein derivative for Montoux test has this original tuberculosis source lot has been finished, right? So whatever purified protein derivative currently available are not manufactured by the Copenhagen company, which was previously manufacturing this RT23 twin 80 purified protein derivative, right? So commercially available PPDs are not being validated because the company, Copenhagen company, has stopped producing this Montoux PPD, right? And they have been shifted for this cutaneous TB. That is the newer test, and it is under the pipeline, which has similar specificity like Igra, which is specific for MTBs, CFP10 and ESET6 antigen, which will have similar specificity results with Igra, but TST is outdated now, right? So you all know this TST and Igra comparison. They will have equivocal result. For mainly TST has equivocal result in non-tubercular microbacteria, then HIV people, then malnourished people, then BCG and recent exposure. And Igra will have no effect with BCG, but it has effect in children and PLHIV, and it may give false results. So Igra is not reliable for testing TB infection in children less than 6 years and PLHIV. So based on this, there are two policies: treat policy and test and treat policy. So these are the target population for TB preventive treatment. On the first phase, India is going to offer TB preventive treatment to the household context of pulmonary microbiologically confirmed TB patients, as well as people living with HIV and children or adults who have compromised immune response, right? So for children less than 5 years and for PLHIV, we have treat only policy, because by testing either by CTB or Igra or by TST, it will have false results, So we are going to treat these household contacts and PL-HIV patients because they are the contacts of pulmonary microbiology confirmed TB patients, and they will have more than 25 times risk. So the TPT regimen is 6-month daily isoniazide or 3-month weekly isoniazide and rifampicin, that is for person more than 2 years, right? So one is weekly regimen, one is daily regimen, right? So again, I am reiterating that 6-month daily isoniazide, that is monotherapy, and 3-month weekly isoniazide plus rifampicin, that is dual therapy. In TB, we are providing multi-drug therapy. So that is why active TB is the absolute contraindication for TPT, right? If the patient has active TB, we are going to provide this mono or dual therapy if we continue TPT. So ruling out active TB before providing TPT and during TPT is the key for managing TB infection. For household contact more than 5 years of pulmonary microbiologically confirmed TB patients, and for these children and adults who have compromised immune response, we are testing by Igra test, that is quantiferon gold plus test, and the state is going to procure end-to-end services. So the agency will go to the patient's home, will collect blood, will run that blood in ELISA, will share positive result, and will inform government, and government will start TPT regimen based on the availability, right? But for TPT regimen less than 5 years and PL-HIV, 6-month daily isoniazide is preferred. For TPT regimen, this household contact more than 5 years and immunocompromised patients, 3-month weekly regimen is preferred. But currently rifampicin is not available. Partner agencies usually donate these rifampicin doses and FDCs containing rifampicin and isoniazide. So whenever the country and the government will have 3 HP regimen, that is rifampicin plus isoniazide weekly regimen, we will provide this 3 HP. Otherwise, country will start TPT with 6-month daily isoniazide after ruling out active TB disease to the household context of pulmonary microbiologically confirmed TB patients, PL-HIV, and persons with compromised immune response, right? So TPT is the most recent advance, and government has started providing TPT. So if you if you have any patient or beneficiary or patient's relative on TPT, we expect mainly that you should rule out TB whenever you meet those patients or meet those contacts, and check for the adherence for TPT and advise them to continue TPT if government has given TPT, right? Another thing is airborne infection control. So preventing TB is the key, and TPT and airborne infection control, these are the pillars of prevent strategy under the National Strategic Plan. So it comprises mainly providing airborne infection control kit, which will comprise of spittoon, a phenyl bottle, and mask or handkerchief. Then fast tracking. Fast tracking means screening, educating, separating, and fast tracking a person visiting a heavy caseload facility, right? So in government or in private sector, when there is a heavy caseload, then this OPD window where the cases have been dispatched, are being dispatched, then the case registering people should evaluate for or should screen each and every patient for chest symptomatic. Patient is having chest symptoms or not. If patient tells he is having cough or rhinitis, then he or she should be given mask, and then a fast track symbol can be place in his OPD paper, and then these patients should be prioritized in every queue, whether it is laboratory, whether it is pharmacy, or whether it is doctor's OPD. And then these patients' early disposal can be ensured if these peons and security guards will understand this fast tracking symbol, right? So these patients should be fast tracked from the facility so that they cannot infect others, and the facilities or the private sector or government sector facilities which will have a lab component, either designated microscopy center or LPA lab or culture DST lab, should have a separate corner with minimal people's movement, which is open and which has direct sunlight, so that a symptomatic person can expectorate his cough and then give to the laboratory, right? So he cannot transmit the infection to others. These are the battery of tests which are available for TB. In private sector, there are more tests which are available, but these are the basic tests which are available in government sector. That is expert TB, that is NAT, that is this miniature polymerase chain reaction. It is either cartridge-based nucleic acid amplification test or chip-based nucleic acid amplification test. Chip-based is known as TrueNAT and cartridge-based is known as CBNAT. So CBNAT will have two types of cartridges. First is commercially available and available in government sector, which detects MTB complex as well as rifampicin resistance. Another newer cartridge is for detecting MTB, rifampicin resistance, plus additional resistance towards isoniazid, FQ, SLI, and ethionamide. These three tests and the line probe assay, which is also a polymerase chain reaction, these are genetic tests and detects genotypic drug susceptibility. What is the difference between genotypic and phenotypic drug susceptibility? That genotypic drug susceptibility testing will detect the resistant gene presence in the sample, right? So CBNAT, TrueNAT, or line probe assay will detect the presence of resistant gene only. So these tests are not advisable for follow-up or for detecting prognosis of TB patients, because it detects only the presence of resistance gene, and any dead bacilli will have this resistance gene presence in the sample, right? So for detecting prognosis or for clinical monitoring of TB patients, there are two tests: solid culture and liquid culture. Solid culture is going to be obsolete in intermediate reference laboratories. So intermediate reference laboratories are mainly dependent on the liquid culture, which are giving result within 6 weeks, right? So this NAT and CBNAT gives result within 2 hours, but as per the caseload, you can get result after 1 day. So when you give the transfer this patient to government health facility, as per the caseload, we can run the test within in 2 hours, but we can give you that is the patient turnaround time. So or the sample turnaround time, we can give you the result within 1 to 2 days. In line probe assay, the positive results can be get within 72 hours, and in the liquid culture, you can get this positive result for within 4 weeks, and for negative result, we should wait for 6 weeks. So this is the NAT machine. First one is the cartridge-based nucleic acid amplification test, and the second one is the chip-based nucleic acid amplification test. These are the bases of universal drug susceptibility testing. The TrueNAT test is indigenous and it is point of care test. CBNAT will require 2 rooms, AC, UPS, but TrueNAT is battery operated and will have storage battery capacity, so you can run the sample at patient's home. So it is point of care test, right? These both tests gives result in 2 hours, and its sensitivity is similar to culture and are highly specific for MTB for sputum sample, not for ascitic fluid or for pleural fluid samples, right? So for sputum, it is highly specific and it is similar to culture, and the main advantage is it detects drugs resistant, that is genotypic drug resistance. And for extrapulmonary fluid, we can run all the clear fluids in these NAT machines, not blood stain fluids or solid samples, right? So sample should not contain blood, and formalin should not be added for preservative. So whenever you send the sample in the government facility or in the private lab, which are having these NAT machines, do not add formalin as a preservative, add normal saline. So these are the diagnostic algorithm which is there in the NTEP. So all the presumptive TB patients should be offered either smear examination or chest X-ray, and these should be offered to CBNAT, right? The second investigation will be CBNAT if smear is positive or chest X-ray is suggestive for TB. If MTB detected in this NAT, CBNAT or TrueNAT, then the patient will be further offered this RIF test, that is rifampicin resistant testing. If rifampicin resistance is present, then the patient will be offered drug resistant TB treatment. If rifampicin resistant is intermediate, the patient will be share the result and will be advised to give second sample, and the second sample will be further run in the NAT machine, and based on the second sample we will decide the fate of the DSTB or DRTB. And if rifampicin resistant is not there, patient is sensitive for rifampicin, we will provide the patient DSTB treatment. But if there is result like MTB not detected, or patient is smear negative, or chest X-ray is not available, there is a possibility of that patient that you can clinically diagnose the patient after having maximum effort of getting sample, right? So you have to have maximum effort for getting sample or chest X-ray or smear examination. But if you cannot have all of this, you can clinically diagnose TB under DSTB algorithm. For pulmonary, for pediatric tuberculosis, if there is a child having persistent fever for more than or equal to 2 weeks with or without known cause, or unremitting cough for more than or equal to 2 weeks, or weight loss of 5% in 3 months, patient is having positive family history. So all these type of presumptive pediatric TB cases should be first offered chest X-ray. If chest X-ray is highly suggestive, then a clinician should try to get sample, and these samples should be offered direct CBNAT or upfront CBNAT, because pediatric samples are precious samples. Sorry. Because pediatric samples are precious samples, and these samples should be offered upfront CBNAT. And if CBNAT is positive, then this patient should be offered DSTB or DRTB treatment. If CBNAT is negative and skin test is positive, that is Igra, TST is currently not reliable. So Igra with quantiferon gold plus. If CBNAT is negative, patient's symptoms are similar for TB, and skin test is positive, then you can clinically diagnose TB. But if CBNAT is negative, skin test is also negative, then look for alternate cause. If chest X-ray is normal, giving normal shadow, and skin test is positive, right? So it is either subclinical TB or latent TB. Give a course of antibiotics. If shadow remains, then try to have, sorry, if shadow remains, try to have at least minimal sample by either gastric aspirate or bronchoalveolar lavage, and offer upfront NAT. If again NAT is negative, skin test positive, you can go for clinical diagnosed TB. But if CBNAT positive, you can go for DSTB or DRTB regimen as per this resistance pattern on the CBNAT, right? But if chest X-ray is normal, skin test is positive, first evaluate EPTB. And if chest X-ray is normal and skin test is also negative, then you should look for alternate cause of pediatric illness, right? This is the MDR or RRTB regimen algorithm. So all the RRTB cases should be offered line probe assay as well as liquid culture DST. And as per the drug resistance pattern, if the patient doesn't have any additional resistance, or if the patient has genetic resistance to isoniazide by either CATG mutation or INHA mutation, right? I am insisting on or part, right? So these patients can be given shorter oral bedaquiline containing regimen, which is there in the NTP. If there is any additional resistance or this shorter oral bedaquiline containing regimen is contraindicated or intolerated, then these patients can be offered longer oral MDR or XDR containing regimen, which mainly contains bedaquiline, linezolid, levofloxacin, clofazimine, and cyclosin. Right? So in DSTB and in DRTB, the NTEP program has mainly oral regimen. All the injections are obsolete now. So in first line drug for DSTB, streptomycin is obsolete. It is not available, or it is not there in the normal this NTP program. It is there for the selected reasons, mainly for the bone TB and for CNS TB. We can procure by our state budget, but it is currently not available under NTEP. So there are fixed dose combinations available for adult as well as pediatric. And these fixed dose combinations are based on the weight bands. For pediatric, dispersible flavor tablets are available. And it is for IP and CP. All these FDCs are quality assured. And if you find any patients who is not affording in your OPD, we can put these FDCs at your clinics, and you can prescribe these FDCs. We will not take any charge. We will only ask for the stock report for these FDCs. So you can prescribe these government FDCs, which is mainly manufactured by Lupin and MacLeod, which is there in the private sector also, right? So these are the quality assured FDCs by WHO, and you can very well prescribe to all your patients or those patients who are not affording the medicine. Then the shorter oral bedaquiline containing regimen. So if you want to prescribe this shorter oral bedaquiline containing regimen, which is mainly for the 9 months of duration, but it is cocktail. So you can see the medication for 9 months, that is bedaquiline. For 6 months, levofloxacin, clofazimine, pyrazinamide, ethionamide, ethambutol, and high dose isoniazide for 4 months, and followed by 5 months of levofloxacin, clofazimine, pyrazinamide, and ethambutol, right? So this is the Bangladesh regimen, or the shorter oral, shorter MDR RRTB regimen, which was previously known, and it had kanamycin and amikacin injections. But from 1st August 2021, state has transferred to transition to this shorter oral bedaquiline containing regimen, which contains no injections. Injections are preserved for the replacement and for CNS or bone TB, and the injection have been obsolete and bedaquiline has taken their place. So this is cocktail. You cannot omit any drug or you cannot add any drug in this cocktail, right? So if there is intolerance or contraindication for any of these drugs, then this regimen cannot be prescribed to any of the DRTB patient. And for those patients, longer oral MDR XDR regimen is the final regimen, right? So this contains 18 to 20 months of treatment, which mainly comprises levofloxacin, bedaquiline, linezolid, clofazimine, and cycloserine. There is no separate IPCP. Bedaquiline can be prescribed 6 months or longer. And pyridoxine should be given to all of the DRTB patients because linezolid causes irreversible peripheral neuropathy and isoniazid causes reversible peripheral neuropathy. So in NTEP program, we are providing pyridoxine to each and every DRTB patients who are on the linezolid as well as high dose isoniazid based regimen. So these are the third DRTB regimen, which is H-mono or polydrug DRTB regimen. So it is from the name, it suggests that it is H-mono resistance. So we can give levofloxacin, rifampicin, ethambutol, and pyrazinamide, provided that patient is rifampicin sensitive. So coming to the standards of TB care in India. So Dr. Satish sir, please let me know if there is time, but I have only few slides remain. So coming back to the standards of TB care of India. So this is the document published by the WHO, and it prescribes mainly 26 standards for diagnosis, treatment, public health action, and social inclusion for every TB patients, irrespective of public or private sector. So as a clinician, we usually ascertain that the TB should be diagnosed and will be managed. But in private sector, most of the time, this public health action part for the TB patients are missing. And what are these? These are counseling of patient and family members, then universal drug susceptibility testing. That means testing for at least rifampicin sensitivity in DSTB and testing for at least fluoroquinolone sensitivity for DRTB within 15 days of diagnosis. Then screening for comorbidities, mainly diabetes, hypertension, and tobacco. Then treatment adherence, right? So it is the key part for this preventing relapse, treatment adherence for 6 months, that is directly observed treatment, right? Which is not sometimes possible in private sectors. Then follow-up care, it comprises 2 types of follow-up, clinical follow-up, which should be there in monthly basis, and laboratory follow-up after IP and CP, contact tracing, providing tuberculosis preventive treatment to eligible household contacts, and direct benefit transfer. So these are the public health action and the heart of standards of TB care in India. If in private sector you are not providing, or if you are willing to provide this public health action, then you can consult your public-private support agency or to the government NTEP staff, and we can very well guide you and will support you in providing this public health action. So while providing this public health action, you may feel that the government staff will not be as professional and will not be humble while interacting the patients on TB, but you should have to rely on us by availing these public health action services to your TB patient, and you have to counsel this patient that the government staff will visit your home and will provide you or will ask you some things, will offer you some tests, and will offer you direct benefit transfer. Then benefit will be credited in your account. So you can give your Aadhaar card and account number to this so-and-so government staff, and our district program, district public private mixed coordinator or our PPSA or G people will support you in providing this public health action to all the TB patients. So if you get yourself registered, if you are already notifying facility or you are notifying TB patients, so I will request that get yourself registered in Nikshay portal. The benefit of registration yourself in Nikshay portal is you can notify those patients directly from your facility. You can track all your patients. You can call all your patients. You can adhere their, you can monitor their treatment adherence on daily basis, and you can supervise the all component of the public health action. Right. So get yourself registered in Nikshay. All your facilities have been registered in Nikshay. You should ask your ID and password from the city TB officer or district TB officer, and they will help you. So that is the theme of the ending TB for by the World Health Organization, mentioning invest to end TB and save lives. So that is all from my side. And the session is open for discussion.
Thank you, Dr. Hardik. It was really a wonderful effort to comprehensively put in such a massive program that the government has undertaken. And you very comprehensively informed us about how government is trying its best. And I have witnessed it because, as some of you may be aware, that IAP, Indian Academy of Pediatrics, has joined hands with government in this NTB program, and we have our own module for spreading awareness amongst the pediatricians regarding these newer guidelines regarding tuberculosis diagnosis and management. And in those programs, it's a one-day workshop, and we have seen government officials regularly visiting this, participating in this program and giving their inputs. And we as pediatricians are also witnessing some of the best behavior patterns on part of the officials who are involved in this NTP. So our great compliments to you, Dr. Hardik, and your colleagues for carrying out this program so well. And we all appreciate that. And now the house is open for comments and questions.
A fantastic lecture, Dr.
Thank you, sir.
Fantastic lecture, Dr. Hardik. Just a small point which I wanted to ask you is regarding pediatric tuberculosis. The basic thing is that we have a lot of challenges because the tuberculin test is not available. And that is a major challenge. And that too, when we get it also, we get it in different strengths. Sometimes it is in 2 TU, sometimes it is in 5 TU. So again, these are problems which are there all the time. So is there any solution that practitioners can get access to reliable tuberculin? The second point which I want to ask you, is regarding nutrition, because most patients who have got really bad tuberculosis are very nutritionally challenged. So is there any effort from the government to see how they're going to be supplemented nutritionally?
Okay. So thank you, sir, for asking this question. First of all, there is no to your first question, because the tuberculin test, which was manufactured by Copenhagen company, has stopped manufacturing the PPD that is coming in the strength of the RT23 between 80 and the strength is 2 TU, right? It is not available right now because the company is manufacturing the newer component, that is CTB, and it is under the pipeline. It is the clinical trial is going on by ICMR, and promising results are there, and it will replace Igra in government sector. So we are going to procure Igra, which I have mentioned, but within 6 months CTB will be available, and CTB is mainly Montux only, but it is highly specific, and it is basically mainly directed towards this ESET6, CFP10 and TB 7.7. That is highly specific for MTB only, not for TB complex, right? So currently there is there are no validated product available in the market. Whichever product is available has not been validated. And answering to the nutritional component, government is providing Nikshay Poshan Yojana benefit, direct benefit under this Nikshay Poshan Yojana part, and government is providing 500 rupees every monthly to all DSTB and DRTB patients for purchasing additional nutritional. But many of the times patient usually not being counseled for what nutrition he should have from this 500 rupees, and 500 rupees is minimal amount. So the counseling part for that he should continue whatever nutrition he is taking, but 500 rupees is for additional nutrition, that is for purchasing any protein rich source like milk, like pulses, like eggs. And government is also supporting these patients by linking this patient to the treatment supporter, which will be a health staff or TB champion or TB survivor, who will explore the possibility of getting this additional nutritional support from the village level or from the community level by meeting with the Anganwadi, or by meeting with the local dairy, or by meeting with the well-to-do family from the vicinity. So if any additional nutritional support can be gained from these sources, then this TB survivor or treatment supporter can get additional nutrition to these TB patients. And in our meetings or in our TB forum meetings, in the tribal areas, DDO and collectors are sound. So we used to put this budget for nutritional kit, providing nutritional kit, which mainly comprises jaggery, pulses, and this cooking oil, something. And we used to provide this kit and additionally add this protein powder, and used to provide this protein powder containing kit to each and every DS and DRTB patients. But these are mainly in the tribal areas, and in some part of this DRTB, some DRTB patients, it is available, sir.
Thank you, Dr. Hardik, for very elaborate answer. Now, to Jagdish and Dr. Hardik both, if we are talking about MANTU or TST, we are during the module which has been made for childhood tuberculosis, if you look at the algorithm, there is no place of TST as far as diagnosis of TB is concerned. It's more of an adjuvant, and its role is in deciding whether to give TPT above 5 years or not. Now the guidelines have changed, and we are covering all age group irrespective of testing them for LTB. So MANTU test as such is not very useful at this juncture as far as diagnosis of TB in children is concerned. If you look at the algorithm, it starts only with some symptoms, 3 criteria, specific symptoms, and then X-ray chest, and then there is a division further whether suggestive of TB or not, and then you proceed further. So I think MANTU test at present, we must emphasize that it has no big role in diagnosis of TB, because we are still seeing pediatricians doing MANTU and then putting the child on AKT only on the basis of positive MANTU, which is very detrimental to the whole program, because we may be missing the resistant cases, because the goalpost has now shifted from diagnosis of TB to diagnosis of resistant TB also. So we include resistance also. Drug resistance, drug sensitivity is very important. So I think my message here to all pediatricians who are in the audience is that do not rely on MT for diagnosis. Make all your attempts to make a microbiological diagnosis, and that is whole the algorithm is aimed at making a microbiological diagnosis. After all your attempts are negative, you may still put a clinically diagnosed tuberculosis if there is a strong suspicion. I think that clarifies.
Yes, sir. In program
regarding MANTU.
That serological tests have no role in diagnosis.
Yes. I think Dr. Pandya, I think what you're saying is absolutely right. However, there is a role for both Igra and TST to diagnose latent tuberculosis.
Yes,
there's no other way you can diagnose latent tuberculosis.
Yes, that is there. But as far as diagnosis is concerned of childhood tuberculosis, active disease, MT has no role. But yes, LTB, yes. When we are talking about TPT, TB preventive therapy, there is a role. But nowadays, what I have heard, the latest update, what Dr. Hardik is also giving, and one of the NTP program which was held in Baroda, the officials told us that the TPT's horizon is broadened now. Irrespective of any test, they give TPT to everybody who is a household contact. Am I right, Dr. Hardik?
Yes, sir. Yes, sir.
So there is a massive campaign for TPT, and I have a question regarding that. Whether this kind of massive campaign, will it lead to any problems of toxicity as well as increasing the drug resistance?
Yes, sir. So I was expecting this question from you. So basically, sir, this TPT. So what I have mentioned in the algorithm, that active TB is the absolute contraindication for TPT. So any clinician or any medical officer at the field level has to rule out active TB before initiation of TPT. Because it is the time to end TB, then it is now or never for this rolling out of TPT. Currently, there is no gold standard test for detecting LTBI also. So quantiferon gold plus or TST or CTB are not gold standard. And these all tests gives equivocal result in PLHIV as well as children less than 6 years due to their variable immune response, right? So, and this Igra test is very costly. So for end-to-end procurement, government costs 2,000 rupees per patient. So for government, it is not possible to purchase end-to-end services right away. So government is direct going for the TPT, that is treat only policy. But again, there is a risk. There is a challenge in public health. But mainly as a public health person, I can say that government used to have this low cost maximum effect approach when they are running public health program. So what is there in government's approach is they are going to launch this TPT until they launch the newer vaccine, that is RBCG vaccine, which has 71% efficacy in clinical trial and which is going to be launched in 2023. So from 2023 onwards, there will be TPT as well as RBCG vaccine, right? That is for the prevention of exogenous reinfection. TPT will prevent endogenous reactivation. But with this significant impact impact on the incidence, incorporating TPT and preventive airborne infection control will be the only key if we want to end TB by 2025. Your concern is legible, sir, because when we roll out TPT at the countrywide level, we will have these resistance cases, but it is not documented, right? Because WHO has insisted to start TB preventive treatment in 2019 to globally, but it is not documented that there is a rise in this DRTB if you go for this TPT. But ruling out active TB will be the key before starting TPT. So
I think that will be the deciding factor for success
that
of
is
this
the deciding
massive
factor.
TPT program.
And if patient is symptomatic while on TPT, then his sample will be directly offered to the CBNAT will be offered to those patients who are on TPT and getting symptoms.
Yeah, there is a question from
There
Dr.
is a challenge, sir.
There is a question from Dr. Sulin Trivedi regarding CBNAT in gastric lavage fluids. It is compulsory. The answer is, I think, in the algorithm, Dr. Sulin, if you look at the algorithm, the emphasis now is on microbiological diagnosis as well as drug sensitive testing. So the answer is yes. Any child in whom you are suspecting tuberculosis, we have to go through that algorithm, which includes upfront CBNAT, as Dr. Hardik has also emphasized.
And sir, pediatric PLHIV are the key population where program is offering upfront CBNAT, because most of the time the sample is precious for us, right? And for gastric lavage and for BAL, if the sample quantity is more, you can go for centrifugation, and from centrifuge sample you can take suspended part and then we'll do this NAT.
So in childhood tuberculosis program, we upfront get this gastric lavage or induced sputum done, and we get the CBNAT free of cost at government.
Yes, free of cost at government.
So the message to the pediatrician is that getting gastric lavage or induced sputum is not difficult. And if you have attended NTP, you will be shown 4 videos in which how to collect those induced sputum, how to do gastric lavage, how to do Mantu. All these are very well given in that video. So pediatrician need not have that kind of inhibition or any doubts regarding collecting the sample. It's an easy OPD procedure. You don't need to admit the patient for gastric lavage. So I think that's the message that we should have. And maybe in next coming few weeks, we'll have childhood tuberculosis presentation also. So if there are not many comments now, I think we are 5 minutes past the time, and we will close the program, and we meet next Saturday again. Thank you very much, Dr. Hardik, for agreeing to be a guest speaker here, and we'll expect some more talks later as the program unfolds.
Yes, sir.
We would like to have follow-up also, and I think there are many queries still left out. So maybe some other time we'll have a combined program of childhood tuberculosis and adulthood tuberculosis with a physician in the panel, so that we can discuss adult issues also.
Yes,
so
sir.
Thank you very much. Thank you, Jagdish, for joining and actively participating in the program.
One small comment only.
Yes.
Yes, sir.
We have seen the star Hardik in the evening only. Now we are seeing in the morning also.
Yes. Very true. Very true. I do appreciate Dr. Hardik's efforts to give such information in a very emphatic and a very crisp manner. I have not seen many people talking about tuberculosis with so much zeal, and that involvement that you have in the program is visible in your talk. Thank you so much for joining.
Thank you, sir. Thank you.
Thank you. Thank you so much.
We end the session here. Thank you.
Thank you, sir. Thank you very much.